Perfetto. Hello, everyone. Here today we are with the Dr. Stefano Colasanto, who is a dentist and osteopath focused on relationship between occlusion, temporomandibular function, and posture. He graduated with honors from Sapienza University of Rome and developed an interdisciplinary approach combining orthodontics, osteopathy, and myofunctional therapy. He's also been involved in postgraduate teaching and in his clinical practice works with both adults and children with particular interest in functional and development disorders, including the link between tongue tie and posture. So welcome today.
Thank you. Thank you for inviting me.
Thank you. So today we will cover, like I said, the topic of the tongue tie. So I'll ask you some questions regarding tongue tie. So let's start. So if you want to actually just say a little bit about you or just your work, and then I'll start with.
I started as a dentist a lot of years ago, and then I specialized in orthodontics. And in 1994, so another millennium, I joined the osteopathy, and it was at the beginning. It was something like leisure time, spare time, and so just to know something new, because in the 90s osteopathy in Italy was not so well known, but actually it became, and it is now, my life. So the joint venture between dentistry, orthodontics, myofunctional therapy, tongue-tie, osteopathy is the star of my ordinary day in my office. So I cannot separate an orthodontic visit from an osteopathic visit from a dental visit. So I try to do everything together.
Wow, that's very, very interesting, and is the future, I think, of osteopathy anyway.
I hope so. I hope so.
And I think it's a topic that so many people will be interested in. So let's start. So regarding the tongue tie, so how do you determine that it's a functional restriction or an anatomical restriction of the frenulum?
So the problem is that actually there is, of course, a functional restriction, and it is also an anatomical restriction, but not every time. I mean, it is very important to understand when a turn time is very short, but it is more important, I think, to understand when, even if anatomically it is not so tight, but actually functionally it is. And I started to understand all the connections between the tongue and the body. And it is very important for me to read, for instance, the book Anatomy Trains by Thomas Myers, because there are a lot of images between the tongue and the rest of the body. So it is not possible to understand all we are doing now without knowing the anatomy. So, I mean that it is very important to understand that it is not a matter of millimeters, of point, of whatever. It is important to understand that it is not how, it is not where we can reach, where we can get with the tip of our tongue, but it is more important, and we know, nobody know very well that it is very important how can we get there. I mean, it is very important to understand that if I raise my tongue and I get along, take along all the floor of my mouth. I mean, the horizontal plane that is at the plane at the level of crankles.
Hmm.
And it is not a normal tongue. Even if I open 40 millimeters, 40 millimeters is the normal opening measure of the mouth. So even if I have a normal opening of 40 millimeters and I can reach the spot, the lingual spot, it is important to see how we can get there. So it's important that the horizontal plane, the floor of the mouth is not rising along with the tip of the tongue. Because
Okay.
even if we can get there, it is a great effort for the body. And I'm doing that just because I was asked to do that. But actually, in my ordinary life, I don't do that because it is too much expensive. So even if once I can touch the top of the ceiling
Hmm.
with my finger, it is not necessary that I am always with the top of my finger on the ceiling if it is too much expensive for me. So it is very important to look at the crankles levels.
Okay. Okay. So when the tongue is moving, so we want to see that actually the tongue has a movement upwards like this, and not like helping with the mouth, like doing like that.
Yeah, of course, of course.
Okay. Okay.
I mean, we have to do to look at the whole of
Okay.
the movement because
Yeah.
it is of course different if I raise my arm and at the same time raise my knee.
Mm,
Of
yes.
course, they are connected. So we have, and it is the main concept in osteopathy. Life is motion. Life is freedom.
Yes.
So I must have a freedom of motion in
Okay.
every single point of my body.
Yeah. Okay. Yeah, that's very interesting because I mean we can look at the whole mouth and see if they really like move the neck and everything just to do this
Yeah,
movement upwards.
yeah,
Oh, thank you for that. And so also in babies, you do the assessment in the same way, in a way. So you look
yeah,
like,
yeah. In the babies, it's quite different. Um, uh, and I think that there is a great, giant misunderstanding
mhm.
because most of my colleagues base all their diagnoses on the ability of the newborn to be breastfed.
Yes.
But breastfeeding is made of two different people. Actually, it is called a diet. There is a mother and a baby.
Mhm.
So, a lot of times, even if the time is very, very tight, so the frenulum is very, very short, there is an optimal
Okay.
breastfeeding because the mother has a great amount of milk produced.
Okay.
So it is just like the bottle effect. There is no difference between a bottle feeding and breastfeeding in that case, except for, of course, the activation of all the muscles of the tongue. Because when we have a breastfeeding, there is a great activation of
Okay.
all the muscles of the tongue,
Mhm.
and it is very important breastfeeding. That's why we have to protect it because during the breastfeeding we have the tongue that only by itself it has to take the nipple, stretch it, push it, and suck from it, and there is just a few drop of milk that the baby can drink. So it is a great effort just to have a very small production of milk. But
Mhm.
there is there is a reason for that because in this way I say that our tongue in the baby, the tongue in the babies is our secret agent in the skull and the cranium. Because with this action, the tongue is pushing on the palate, and it is enlarging it, broadening it, and since the cranium is a sort of building, and the first floor is the mouth, on the second floor is the nasal fossa. So
Mhm.
we have a general enlargement of all the nasal
Mhm.
pyramids, and so we have a beautiful mouth with hopefully a beautiful occlusion, but more important, we have also a good breathing
Mhm.
ability. So every time when I visit a child of 7, 8 years of age, and it has had a tonsillectomy or adenoidectomy, every time he has or she has a tongue tie.
Okay, okay. All right. So there is a correlation then with the removal of the tonsil adenoids and the tongue
Yeah,
tie then.
yeah, yeah.
Okay.
Also because it is very rare, and uh, I think that in general medicine, we we shouldn't use two words, never and always.
Hmm. Yeah.
So, because general medicine and also osteopathy, of course, it is not maths. It is not a precise science.
Mhm.
So, in the most of mostly or rarely, mostly when we have a chantai, it is very difficult to have a good swallowing pattern. So if we have a good swallowing, we have a sort of we actually we suck our saliva, our bolus, our food, but at the same time we suck also all the mucus
Okay.
from the nose, from the
Oh, yeah.
sinuses,
Of
and
course.
so on. So and we do it, we perform it 2,000 times per day,
Okay.
every day, and it is mandatory.
Okay.
So we must do it, and we must do it 2,000 times per day. So if it is good, we have a sort of uh, we free all our deposits of mucus here in frontal sinuses, maxillary sinuses, and also sphenoidal sinuses, everything, because all of them are joined together. It is
Yeah.
just one system of little caves in our school, and all of them, 2,000 times per day, are freed by the
Mhm.
swallowing. On
Okay.
the other time, on the other hand, if we don't have um, correct swallowing, we are pushing the mucus in all these holes, all these rooms, all these spaces. So the mucus is produced at the same time every day with the same speed, the same amount, but it is not absorbed. It is pushed and it stays there, and it can produce inflammation and whatever. For instance, it is very, very frequent, mostly
Mhm.
um,
Mhm.
itis, acute otitis is a sort of rule in babies or in toddlers with anti.
Okay. With otitis then, you said.
Yeah,
Okay.
otitis.
Okay. All right.
So it is in my analysis, in my paper in the first visit. Did you have otitis when you were baby, when you were toddler, and up to 7 or 8 years of age? Because we know that the Eustachian tube um, change the orientation. So
Yes,
after 7, 8 years of age,
improves.
yes, it
Okay.
becomes very inclined. So it is easier
Okay.
to free from the to set it free from the mousse.
Okay. So you said like a test that you do is like how they lift the tongue during the assessment. But so regarding your assessment, is there anything else that you do, or is there any red flags that you see and you're like, okay, we need to cut or like do a laser on this child or this baby because it's almost sure, no, like there is a
Uh,
topic.
um, that is another topic. First of all, I in babies I use just scissors. I
Okay.
do not use laser,
All right. Mm-hmm.
and because I think that there is no need to use laser.
Mm-hmm.
I don't generally. I do not cut labial, buccal,
Okay.
friendly, but just tongue-tie because it is the main reason of restriction that we can have in
Okay.
babies. Then there is another point of view. In babies, it is a matter of half a second. It is a surgery very rapid, very short, and with absent or very small bleeding with no pain. 90% of babies in my office are sleeping after the tender release. So it is also because they are breastfed just after the
Mhm.
release. So we can join the trauma, but it is not a trauma because it is not memorized because they are too young. And there is a sort of compensation, a sort of gift
Mhm.
because you are fed by
Okay.
your mother. So, okay, there is a package, a gift
Mhm.
package.
Yeah. Mhm.
And I think that since I used to perform these releases in newborns, children, and adults, and I see all the effects of tongue-tie in adults. And
Mhm.
in adults, the the general sentence of my patients is, "I have these symptoms, blah blah. 3 words for a lifetime."
Okay.
So I have a lot of patients with headache, vertigos, arthritis, back pain, cervical pain, a lot of things for a lifetime.
Okay.
I can remember a moment in my life in which I was without these symptoms.
Mhm.
So it is a slavery.
Yeah. Yeah.
Tie is a very complex restriction of motion. So, if it is possible, whatever is the symptoms, even if this is my opinion, even if there is no real breastfeeding problem,
Mhm.
but mostly Tentai can cause lots of problems
Yeah.
in adults and in young adults and in teenagers and whatever. So, since the surgery before 6 months, because I perform a surgery before 6 months
Mhm.
and after 6 years,
Okay.
not not in
All
between
right. Why is
in
that?
between. Why? Why? Because it is the tensor release is made of two parts.
Mhm.
One is the release, that is the shortest part, but the second part is most important because it is the gym, the
Yes.
stretching, the tummy time,
Mhm.
and of course breastfeeding because we have to avoid the relapse of
Mhm.
Chantai in this period. So it is easy, very easy to perform some stretching, gym, or whatever before 6 months of life of age. It is completely useless. It is
Mhm.
useless to have a Chantai release at 1 year, 2 years,
Okay.
3 years, whatever. It is useless because it is not Well known the necessity of the gym after, so the sort of rehabilitation,
Mm-hmm. Okay.
functional rehabilitation of the tongue. So most of uh, pediatricians, of surgeon, of ENT thinks that tongue release is enough. Okay, bye bye. No, it is
Mhm.
just the beginning.
Okay.
And it is very important that the parents must be educated to do stretching for 1 month, not for 1 year.
Okay.
1 month is enough, but it must be made. It is very important.
Okay. Yeah, because otherwise you can reattach, right? A lot of
Yeah,
pain.
yeah.
Okay. So,
It is the rule. Without gym, it is the rule.
okay. So after the 6 months of age, so it's hard to do the exercise because, of course, the baby doesn't allow you to do,
Yeah.
and also with the introduction of food, maybe it's harder to do the exercise or.
Yes, but it is not possible to do perfectly, and we should have a minimum, at least, of compliance by the baby. And after 6 months, it is
Yes.
very hard. And usually, since the breastfeeding in this gym uh, pattern, breastfeeding, in my opinion, is 60% of
Okay.
the action against the relapse. The stretching is 30% and tummy time is 10%.
Okay.
So generally, after 6 months, breastfeeding is very rare, at least
Okay.
in Italy, at least
Yes.
in Western world.
Okay, so the exercise you give is more like I saw some exercise they give like put the fingers like close to the tongue and then just move a little bit the tongue, or do you recommend any exercise in particular?
No, no. In particular, it is very simple. It is a stretching under the tongue. We could see a sort of diamond shape because the cut, because actually the frenulum is not a rope; it is a
Mm-hmm.
tent.
Yeah.
If we think of a tent made by the Indian in America, native in America, and we cut on the top, the
Mhm.
tent does this,
Okay.
okay,
Yeah.
and enlarging it, there is a diamond shape resulting, and this diamond shape must be closed as the curtain of a theater and
Okay.
not just like a window. That's
All
that's
right.
what we say to our patients, to recommend to our
Okay.
patients. So it is very easy to take the lower gums of the baby. So we have the head of the baby, the baby's head here, and the feet are on the other side, and we can put our thumb on the lower gums of the baby, and with the other two fingers, we put these two fingers under the tongue, and we push up the tongue toward the palate, and we can stay there just for 5 seconds,
All right. Okay.
5 times per day. So I call it the 5 for 5 exercise. So stretching, we have just to stretch
Yeah.
the base of the tongue 5 seconds for yes, 5 times per day.
Okay, and this is the main exercise then that you
Yeah,
give.
yeah,
Okay, because I heard some parents that are given the exercise where they put the fingers, but the
yeah,
baby
yeah,
a lot of gag reflex also, and they can't, they're not able to do the exercise then. So this is also a good alternatives.
yeah, yeah, yeah. The problem is that we have also to imagine that parents with a very young baby, they have a lot of worries, a lot of activities, a lot of things to do and to look after. So I tried to avoid to give them lots of instructions because I'm sure, I'm quite sure
Mhm.
that the more, the less.
Yeah.
The more instructions you give them, the less they are able to follow.
Okay, okay. So when you see a baby for the first time in your clinic, and then the mom tells you, "Okay, I'm in pain breastfeeding. I like bleed sometimes. I'm just not sure if it's a tongue tie." So then you go to the baby mouth, and then you assess if there is like a restriction there. So you just go inside, or you base yourself more on the symptoms then, or do you go there and then assess the tongue tie just to like help people assessing like what should I do when a mom comes to me and say I have pain breastfeeding, other than treating all the musculature here, like really in practical way.
There are two main tests. The main test is to push up the tongue because I have to see if there is a frenulum
Yes.
and a tongue tie. And the second is the Murphy maneuver. I mean to I told them uh, I tell them that under the tongue, it must be the same feeling as I'm touching the my cheek.
Okay.
So it must be very smooth without any interruptions. And we can have two different feelings. Sometimes we can feel just like a little wall, and this is the anterior tongue, and we can see it. It is a very evident restriction,
Okay.
but there is also the posterior
Yeah.
tongue that it is just like a sort of little dome,
Mm-hmm.
and it is not a thread, it is not a little rope, but it is just like something rounded, and it is the most difficult to see,
Yeah.
but also the most hidden, and it is very important because the posterior tympani causes the greatest difficulties for mothers, because it is the main reason for the breastfeeding to be stopped because there is no suction action
Okay.
by the baby because the posterior tympani um, uh, uh, um, uh, avoid the tongue to rise up, to rise
Okay.
it to the palate from the beginning because it is not on the
Mhm.
tip. Because if it is on the tip is locked, but the body of the tongue can raise up. But if we are locked here at the beginning of the tongue, it is not possible for the tongue to rise. And actually, the shape of the tongue is a sort of cup.
Yeah.
And
Okay.
so it is something concave and not convex. So there is no um, possibility for the tongue to push
The
the
more
palate
than
and to enlarge the palate and to do all the action we mentioned before.
yes. So then it creates all the like the nasal congestion and
Yeah,
everything, and
yeah, yeah,
like,
yeah,
because of this expansion mechanism.
yeah. It lacks completely the expansion.
Okay, all right. And then that's very, very interesting. Like just I didn't know about like the tip and the I mean I knew about the different type of tongue tie, but didn't know like the the problem that could cause like a tip and
Yeah.
the back. It's very interesting. And
And another thing, it is very important, as the Americans used to say, there is not a short tongue tie, long tongue tie, and they say it is just like a pregnant woman. It is not almost pregnant, little pregnant, or
it's a
tongue
tongue.
tie. Yes, it is not. There is no borderline tongue tie.
Okay.
Tongue must not be there. Stop.
Okay. Okay. No, that's so interesting. Let me just check the. Okay. And what about like so talking more like also osteopathy, like craniosacral and everything. So do you observe any patterns between like the tongue tie and dural tension, for example? Like we talk about like the temporal, the ethmoid, and everything. So you see probably like a dysfunction on those bones. But do you see anything like connecting on dural tension or any craniosacral rhythm with the tongue tie?
A lot. There is not a cranial model and cranial pattern. I mean, it is not a matter. It is, I could say they are mostly present um, in torsion, cranium, or in side bending, or no. There is not um, a pattern of cranial dysfunction, even strain, vertical strain, and so on. Tentai affects all the cranium in the whole.
Mhm.
Um, and the problem is that we have, on one hand, one side, we have this enlarging, this pushing action on the palate that I mentioned before. On the other hand, we have a very important action on the activation of the lingual spot. The lingual spot is more or less 1 centimeter before the incisors, and it is the first um, palatine wrinkle, the first line on the palate. So, and it is very important because it is the exit of a branch of a trigeminal nerve,
Mhm.
and the trigeminal nerve is the greatest nerve of all cranial nerves, and it is very, very big as amount of fibers. And you have to think that the trigeminal nerve uh, takes 50% of all sensory inputs of our body.
Okay.
50% of all our sensory inputs travel in the trigeminal nerve. So if there is this activation, it affects all the body. If
Mhm.
we miss this activation, it affects all the body.
Okay.
And we can see a different movement, a different plasticity, a different um, feeling of the cranium if you are doing our CST of whatever as orthopods. Uh, just if we put the tip of our tongue, or the tongue of the patients, of course, on the lingual spot,
Okay.
the cranium changes a lot. It is
Yes.
more the motion is more is broader, and you can feel it much better. And on the other side, if it does not happen, it means that the cranium is very stiff. It's very compressed.
Okay.
So you could also make a sort of a diagnosis. And generally, look at the posture of patients if they have lingual on spot, the tongue on the spot, and the tongue in ordinary, usual position.
Okay.
They change completely their posture.
All right. So you're talking more when the patient they have more atypical swallowing and they put the tongue on the teeth and then make them put on the lingual spot and then see how they changes on that.
Yeah, exactly, exactly.
Okay.
So, and it is very, very important.
Okay. And then after you see this change, so of course atypical swallowing, I mean, from what I've been told also university, is hard to correct after a certain age because the tongue is used to do, but
Uh,
I'm not sure.
the older baby I treated was 80
All
years
right.
old, and it was a lady, and she was wonderful. I have, I still have in my mind the MRI of her neck, and I'm sorry for her, but it was a mom's neck. It was destroyed. 80 years of incorrect swallowing devastated her neck. But nevertheless, she performed the myofunctional therapy for 6 months as usual. And every time, I mean, every 15 days at the check, she came to my office with a medical bulletin with less symptoms. So, hi, doctor, these weeks, I don't have this anymore. I don't have this anymore at 80 years of age.
Amazing.
It
Okay.
was amazing. And I actually, it was 20 years ago, so I don't think, I hope for her, but I don't think she's among us anymore. But anyway, I learned from her a lot
Yeah.
because I'm doing this investigation on tongue. I'm doing that. I've been doing that for 28 years,
Hmm.
so almost 30 years. So at that time, I was at the beginning. It was more than 20 years ago. So anyway, so there is no limit, but it is very important that we must keep in our minds that there is no orthodontic appliance,
Hmm.
even a froggy mouth or whatever, that alone can treat incorrect swallowing pattern. We have to do a gym. The gym is my functional therapy, and it must be performed for more or less 6 months. So it is not a matter of we can do it in 6 visits or 10 visits or whatever. It is a sort of path that you have to walk through because
Hmm.
you have first to um, wake up your system
Hmm.
because it is not a rehabilitation, it is an habilitation
Hmm.
because you never work properly
Yes.
in that field. So it is a very important concept. So the first period is wake up. The second period is to strengthen it, to learn how to use it. And the third period of my functional therapy is automatization. I
Yeah.
mean, it must be automatic for you to perform a normal, proper swallowing um, pattern in the right way, not because you want it, but
Hmm.
because your brain wants it. So,
Okay.
because your brain automatically understood that it is the best way because it is the less expensive way
Yes.
with less muscles involved.
Okay. Yeah. So after 6 months, you become more automatic in these movements and
Yeah,
the
yeah.
lingual. And can you give just a few example of like the exercise that you recommend? Just a few, like not
No,
a
no,
lot.
yeah, yes. Of course, they are. For instance, we use a lot of little round elastics. They are very little. And for instance, you have to stay 10 seconds 3 times per day with the tip on your tongue on the lingual spot at the beginning without anything. You have just to stay there. And
Hmm.
sometimes it's so hard that they cannot stay there more than 5 seconds.
Wow. Okay.
Because the tongue is,
Yeah.
yes, is starting to shiver. Okay, so and then when they can reach 5 minutes in that position, we start to add little elastics So the first is on the top and on the tip of the tongue, and it is different because you have to uh, pay attention to stay there, and you have to pay attention to keep something to stay there. So a greater attention. And attention is the first step for the brain to memorize, to remember, and to fix a pattern
Mm-hmm.
of behavior.
Okay.
So, and so from here, 10 seconds, 20 seconds, up to 5 minutes. And
Mhm.
then the second elastic
Okay.
here, they are just like elastic rings. So the first year, the second, and the third, and we at the end, the patient must be able to have 7 different rings, elastic rings, on the body of the tongue, and he must be able to stay there for 5 minutes without moving it.
Wow, that's impressive.
Yeah,
Okay.
yeah.
Wow, that sounds very hard for someone that is not used to
It
do this.
is, it is, it is very hard, but it is what we normally can do if we don't have any problem with our tongue.
Okay. All right. Well, that's so interesting. And also like talking then about this incorrect swallowing. So we talked before about the tongue tie and everything. Um so like you said, like the tongue tie, especially the posterior tongue tie, can facilitate a little bit this atypical swallowing, right? So if we don't correct a posterior tongue tie or the movement of the tongue when a
Well,
baby, then it's
the effect is similar. Posterior, anterior are
okay. But it can
same level.
facilitate the atypical
Yeah,
swallowing then. Okay.
yeah.
So yeah. So sometimes we can see also in adults when maybe the cranium or the bones are no very like you can see you don't see this expansion. Then just seeing on the face of the person, can you predict
Yes,
if there is like okay.
yes. Of, and another thing, as an orthodontist, the first thing I used to look at is, of course, the tongue, because we have three main activities, mandatory activities in our life that they are breathing, swallowing,
Yep.
and chewing.
Yes.
And so if I see a narrow palate,
Mm-hmm.
first thing I do is not to think about expansion, orthodontic expansion, but I think to check the swallowing pattern.
Okay. All right.
And so I have to, firstly, I have to uh, educate the patient to swallow properly, and
Mhm.
then I think of any orthodontic appliance.
Okay, all right. Yes, because usually, especially when, like you said, narrow palates, so a lot of like the teeth close together. Usually, there is this atypical swallowing or the tongue
Yeah.
tie that creates this expansion. Okay. Do you see any? So talking about teeth, so we talk about narrow palates, but do you see any correlation with other conditions? So, for example, crossbite or open bite, yes, with the typical swallowing, but okay, so
I have lots of photos, lots of pics with, for instance, different shape of the tongue. So, for instance, we don't have to think of our tongue as a symmetrical shape, but very often there is a half tongue that is smaller than the other half,
okay.
and on the same side we can see a smaller half palate
Oh, that's
with a
interesting.
different, and that is the crossbite,
All right.
because that palate is, um, I mean, it is just like it was less inflated by the
Mhm.
tongue, because there the tongue was weaker, so the palate is less inflated than the other side, but the mandibula, the jaw, the lower jaw is on the same size, more or less, and there is a crossbite.
But in
So
that
it is.
case, yeah, sorry, go on.
No, 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 no. See, see.
But in that case, do you then correct the tongue as well, or do you do more orthodontic?
Absolutely, absolutely. First time.
Okay, all right.
99% of my cases, I treat first tongue, first the tongue, then the teeth.
Okay, so make the tongue more like mobile on both sides in this case of the crossbite. Then,
Yeah,
then
yeah.
okay, work on the. All right, okay. I didn't knew about the crossbite. That is like this expansion. It makes
And
so.
sometimes, yes, and sometimes I don't have to treat the crossbite anymore.
Okay. All right. Yes, because then there is this integration then, especially in a
Yeah,
child, of
yeah,
course.
yeah,
Okay. Let me just check. All right. And then connecting then to the cervical and the rest of the body.
yeah.
So if we, of course, the tongue influence everything on the body, but do you see any like more like places of the body or patterns or in the child or baby or adult, and then they're more common in when you see a tongue tie. So then any dysfunction that are correlated to the tongue tie in the body.
What if I tell you that we found lots of correlation between Tantai and L5S1
Oh,
hernia?
really? Wow. Okay.
Yes. And actually, at the beginning, I mean, me and my staff with other osteopaths, orthopedics, and so on, we started to enlist our patients with lumbar hernia. Then we stopped because they were too much, too many.
Yes.
So, just because deglutition is a vertical matter. We have the trachea going up, the epiglottis is going down to avoid the food going to the lungs. And so the channel is closed, temporarily closed. We cannot swallow and breathe together at the same time. So we have this movement, and then the food is passing through the esophagus that is behind, and then we open again the tunnel, the channel.
Okay. Yes.
Okay, so this is what happens 2,000 times per day.
Mhm.
But if it is not possible this way, and we must swallow because it is mandatory, it is not possible. If it is not possible this vertical, we have to uh, push down our head and neck 2,000 times per day.
Doing this movement all the time. Okay.
It means, yes, it means that first head, then neck, then shoulders, then whole body is following this necessity to push forward. And so it is useless to go forward and back 2,000 times per day. My brain decides that it is better for me to stay forward. That's why the most tight is the tongue tie, but also without tongue tie, just with an incorrect swallowing pattern. The most tight it is, the most forward is my body, and beyond a certain limit, I have, of course, to go back with my
Mhm.
spine, and the change of bending is on my lumbar spine.
All right.
And
Okay.
so we have an hyperlordosis, and the top of the hyperlordosis is on L5S1. That's why it is very frequent to have, and it is the same thing, the same reason, because of we have the the apex of the other lordosis. I mean, the cervical lordosis is C5. So
Okay.
we have a lot of problem problems on C5, just C5, not C4 or C6, just C5. And so it happens to me to diagnose incorrect swallowing pattern just looking at an X-ray, cervical neck, a cervical X-ray. If there is something just on C5, something
Then it's
strange,
probably
there is yes.
okay. All right. So when you do a treatment, of course, you treat the tongue and everything, and then you treat the secondary. Then usually is like C5 and L5. You just to
And
compensate. Just you
yes,
focus on.
I ask the patient, at least I have to say, to tell them that there is a swallowing problem and a swallowing issue. I treat them as an
Okay.
osteopath, and I can set them free with all their blocks, but at the same time, I have to say that it will be very probable that some of all of their symptoms can happen again, just because the cause is not on the spine but on the tongue.
The tongue. Okay. And also regarding headaches and migraine, you see a big correlation with the tongue,
Yeah,
right? Yeah.
yeah.
Again, with expansion and everything. So, okay. So just to
Yes, but
like
also for the
close up
compression, also yes, also for the compression of the cervical spine. So they're doing
of this
2,000 times per
well.
day. Yes, yeah,
Okay. Yes. So all right. So yeah, compression like this with the cervical spine and
yes,
then the frequency of migraines, of course.
yes.
Okay. And so I just wanted to ask a question out here. So, what are the most common mistakes you see when you see osteopaths when assessing tongue tie? You probably had experience seeing also other osteopaths or helping other osteopaths. Have you seen any like mistakes that like they do usually when assessing tongue tie?
The problem, well, in classical osteopathy, the jaw
Mhm.
was not very well considered. It was underrated, the effect of
Yeah.
the chewing effect on um, yes, on the lower jaw, just because it was not connected with dura mater.
Yes.
So it was something outside the cranium, outside the dura system. So it was not so important. Actually, now we know that it is not so, and the chewing, the contacts, the teeth contacts are very important to stabilize the to keep the stability of our body, because we have to think that our balance in the space depends on the uh, the uh, the level of the balance of course, ears, the balance of eyes, but the balance also of teeth contacts of TMJ. So if all of them are parallels, so they have three different planes all together symmetrical, it is very uh, rare to have a problem of vertigo, dizziness, or whatever.
Mhm.
Otherwise, if we have a perfect eyes level, perfect ears level, but we have occlusion this way, we can have a lot of problems with our cranium because we oblige the cranium to balance this contact uh, with, of course, our neck, our upper
Mhm.
neck. The first three cervical vertebrae are affected. And so there is a sort of a short circuit between our skull, our cervical spine, and most of our balance depends on this system. So
Okay.
uh, our health, our general health, depends a lot of what happens here. So also Viola Freiman uh, wrote a lot about the importance of the mouth floor
Okay.
as something to look at and to check because it is a sort of hub, a sort of um, platform to spread loads from the cranium, from the body. So it is very important that this pavement, this platform, this floor must be connected with other diaphragms because it is a really excellent
Yes.
diaphragm with other diaphragm just like tentorium, thoracic outlet, and diaphragm and pelvic floor. So they are all of them are connected. So it is not possible in in modern osteopathy and in modern posturology and also in chiropractic, whatever, to avoid to not to rate and not to consider the mouth. And mouth is
Okay.
teeth and tongue. Teeth and tongue.
All right. And you mentioned some books. So you mentioned Viola Freeman that she did some books.
Yeah.
Do you, and then we will close up. Do you recommend any resource or anything that if somebody wants to know more about the topic or anything to know more about the teeth, the occlusion and everything?
Well, actually, also on PubMed, it is possible to find a
Okay.
lot of papers, and nowadays it is very frequent topic, the the connections between jaw and the posture and whatever. And I recommend to investigate on fascia effects.
Okay.
And beyond the book by Tom Myers, there is also the book by Carla Stecco. It is the Atlas of the Fascia or something like
Okay.
this. And there is another book by Sergio Pauletti that is called Fascia. And
Okay.
all of them are very educational, but also very precise, very scientific.
Okay.
So I think that you must not have it. I mean, you must. It is mandatory for you as an osteopath to have all these three books.
Okay, yes, because also regarding the teeth, is not well known the connection between a teeth that is like touching each other, like the teeth,
Yeah,
and osteopathy. So it's very interesting if people want to deep more. Because also myself, when I looked online, when the teeth are like touching together, I never found too much on the topic. It's always the
yeah.
tongue, it's always the palate, but not much about the teeth or the treatment of the teeth. So it's
Yeah.
very interesting also on PubMed too.
Yes, we in Italy we perform a sort of master course, master degree. It is we call it the postural triad. I mean, it is made by me and an orthopedic, an osteopath, and an optometrist,
Mhm.
optometrician. So we joined together 25 years ago to study all the connections between eyes, spine, and occlusion and mouth. And so we uh, went deeper and deeper in this field, and we are doing this sort of master. It is in 3 meetings or 3 days, so it is a very large topic, and
Okay.
it is very important to understand it. And I think that all these concepts must be in the back, in the bag of the modern orthodontics.
Yes, yes. So just to close up, so you're talking about this master. So do you know when it will be held in Italy? Like, do you know the date exactly, or anything that you
If you want, yes, next master will start in October.
October,
It will be October, November, and December.
right?
You can find it on Facebook or Instagram. In Italian, it is triade posturale.
Okay.
So you can find it,
All
and
right.
you can find me also on Instagram and
Yes.
ask me or Facebook.
And is there any of the masters are coming up in the around the world?
We have been asked to move abroad, and we are trying
Okay.
to
Okay, just
yeah to do it. Yes, to do it abroad in next year.
okay. That will be very
Yeah,
interesting, I think, for the people
thank
joining.
you.
Okay. All right. And thank you so much then for your
Thank
time
you too.
and patience. It was very, very useful and really thank you so much.
Okay,
I'll
I'm so
stop.
happy for that.
Thank you. Bye. Bye
Bye
bye.
bye.
1 second. I'll just stop the record.